welcome to our webinar today on mental health education for future doctors and nurses. My name is Charlotte Hanlon. I'm co-director for the Centre for Global Mental Health at King's College London. And normally I live and work in Ethiopia, where I've got quite a lot of experience thinking about how to educate medical students and other health professionals with mental health. Such an important topic that we're focusing on today. And we're looking forward to our wonderful panelists and hearing their expertise that they'll be sharing. There'll also be opportunity for audience participation. So as you're listening, please put your questions or your reflections and comments in the chat. And about 25 minutes in, we'll have a time to put those questions to the panel. So just before I do anything further, let me just ask Antonis to briefly introduce himself as well.
Thank you, Charlotte. Hi, everyone. Just a brief welcome from me. Antonis Kousoulis. I joined recently as Director of Partnerships United for Global Mental Health, and in that capacity, I'm leading the Secretariat for the Global Mental Health Action Network. So thank you so much for joining. I'm looking forward to interacting with you over the coming weeks and months. And yeah, please do let us know where you're coming from in the chat and with your organization, your country, whatever feels appropriate.
Exactly, that would be wonderful. Great. So let me get the panel to introduce themselves to you. So first of all, Brandon, over to you.
Thank you, Charlotte. And hi, everyone. My name is Brendan Gray. I'm a technical officer in the mental health unit at WHO headquarters in Geneva. It's a pleasure to be with you.
Thank you. And Salman?
Hey everyone, I hope you're doing great. I'm Salman Khan, a medical intern based in Mumbai, India, and I'm the liaison officer for public health issues at the IFMSA, also known as the International Federation of Medical Students Associations.
Brilliant. Sankar?
Hi all, I'm Sankar Andeni Kumar. I'm a family physician from Sri Lanka, and I'm representing WONCA, World Organization of Family Doctors, and I'm an active member of the WONCA Working Party on Mental Health, as well as I'm the immediate past Young Doctors lead of WONCA. Thank you.
Brilliant. And Fajana?
Hello, good evening from Bangladesh. My name is Farzana Sharmin. I'm completed my post-graduation in clinical psychology, working in development sector in Bangladesh for past 10 years. Right now, I'm working in a BRAC as a health program manager, mental health unit.
Brilliant.
Thank you.
And we have one other panelist as well who will we'll have a pre-recorded message from him because it's very late. He's based in Australia. So that's David Stewart, who is the Deputy Chief of Nursing from the International Council of Nursing. So we have a very great panel to cover this topic. And we're going to start with a question posed to Brandon Gray. So Brandon, the World Health Organization has been leading some work on pre-service education on mental health. Could you give us an overview of this and tell us where does pre-service education sit in the training continuum and what progress has been made so far?
Thank you, Charlotte. Sure. I think the first thing I should do is probably address the elephant in the room whenever I talk about this topic, and that's what does pre-service education mean? I think that's a somewhat confusing term for a lot of people, but we use this term to convey specifically education that occurs in universities, colleges, schools before a health professional enters the workforce, before service. And particularly in this project, what we're focusing on is first degree education. Sometimes that's called undergraduate education in many countries, but not always. But in any case, we're focusing on first degree education and not specialist education. So we're interested in this topic of enhancing the type of education that doctors and nurses receive in their medical education before entering service, I think for perhaps obvious reasons. We all know the figures, right? The needs are massive, nearly a billion people living with mental disorders globally. Workforce that is quite scarce, right? Very low in many countries, and even then, quality of care that occurs is not always up to the standard we would hope it would be. So we all know there's a need to better integrate mental health care within general healthcare settings as a way to address the gaps that are there. What's typically done, I think many of us know, is these in-service approaches where it's training a doctor or a nurse or another health professional who's already providing other services and how to better provide mental health care as well. I think we definitely know that that's essential. That's still a very important practice. But we also think that taking this pre-service approach towards an educational setting allows for maybe a more sustainable and a longer term impact by building larger workforces, workforces that are perhaps more able to learn in depth the competencies through the education that occurs at the university setting rather than in service where they have to be briefed, they have to be targeted for obvious reasons. So this is kind of why we've taken on this topic and found it very important. But we began in 2022 without an idea of really knowing exactly where to go with it. We wanted to do something to increase the work, but we needed to understand what. So we started by doing a scoping review of scientific literature, but also a lot of gray literature, reading over curricula from across the globe, trying to understand what are different universities doing already in this area, what are the similarities, what are the differences, what are the gaps. We also conducted a large number of key informant interviews with professors and other experts who are working in this area to kind of understand, again, what's happening, but what should we as WHO do to move it forward. And I have to say, this background work was led by my colleague, Dr. Sherry Ann Kramer, who did a huge amount of effort to really get us to a point of kind of understanding the status of things and where pre-service education typically was in some of this information. So we culminated all of that work with a consultation in 2022 in December to get some recommendation for what WHO should do to kind of move forward in this area. And one of the key things that came out of that meeting was a recommendation that we create some sort of guidance that medical educators, university administrators, and others could use to develop pre-service education curricula for future doctors and nurses. And so that's what we've been trying to do since then. And I think what's particularly interesting about the approach we're taking is we've taken this competency-based approach where within the guidance we're developing, we're trying to define what are the attitudes that all doctors and nurses should have, regardless of what the specialization they go into or what area of work they focus on after that first degree. What's the knowledge that should be there? What are the skills that should be developed? And how do those contribute to a set of core competencies that, again, we would say all future doctors and nurses should have? So in developing this guidance, we've come up with 12 core competencies that, again, we define kind of the attitudes, knowledge, and skills that goes into each. And then we've also tried to structure some information on how you would develop learning content to develop those competencies in a medical science education program, for example, or a nursing education program. So we're really hopeful that this will be able to be used and to have an impact in some university settings or countries where there's interest, but perhaps it's not occurring yet, or it can be strengthened where it is occurring. But this is where we are now. We have a guide. We're going to be sharing it for external review soon. We hope to publish it this year, but I think it's maybe only can be seen as perhaps a first step. We want to try to work towards the next step of then disseminating this topic further, disseminating this guidance, and working with partners to actually implement it in countries. I think that's challenging because this area is underfunded. It's difficult to fund. The impact's not immediate. It's hard to see the impact in the short or even the medium term. And so there's less funding available, but I think it's very important to really making a difference in education settings.
Thanks so much, Brandon. It's great to hear what WHO is up to in this area. And we obviously look forward to that coming online soon. We'll now go to Salman, and I'm going to ask you a different question. So, as future medical doctors, what will be the impact of integrating mental health training into medical education from your perspective?
Thanks a lot for giving me the floor, and let me thank WHO and Brandon for taking the initiative for the pre-service training and working on it. As we all know, and we all agree that mental health conditions are the leading cause of disability worldwide, and let's say around 1 in 5 of the world's youth and adolescents suffer from a mental health issue in in because of multiple social determinants as well. And it's let's imagine how this pre-service training, if integrated worldwide everywhere, would contribute to promoting health for all. And considering the problems that we have with respect to access to treatment because of underdiagnosis, a lack of awareness, inadequate prioritization and policy frameworks, as well as the existing stigma. Having a pre-service training would help us in multiple ways. First of all, it would strengthen the mental health component in the training of all healthcare professionals to ensure there's a fair distribution of mental health providers, given the current burden we have with the number of mental health professionals or mental health service providers, and at the same time the ever-growing burden of mental health issues in the populations. This would also, a pre-service training would also help us to provide human rights oriented and evidence-based mental health services. And as a result, we can also eliminate stigmatization and human rights violations from people who suffer from mental health conditions. Moreover, this could help us to remain mindful as healthcare professionals of the rights infringement imposed on individuals because of stigmatization. And this would help us to ensure human treatment for these patients. And let's talk on the flip side or the other side of the pre-service training. This would potentially come with benefits for healthcare providers too. Healthcare providers would then understand, the alarming signs of compassion fatigue and vicarious trauma they may suffer from. I did quote an anecdote in the previous webinar that happened early this morning. I work in a government-based setup, and us as medical interns are exposed to psychiatry, but we're still not equipped enough to understand how to communicate with patients. And we often feel helpless as undergraduate medical interns or students for that matter, because we're still not exposed to many such, concrete treatment and communication points that we need to take into consideration while providing mental health services to someone. And having something along the lines of pre-service training would help us to advocate for promotion of mental health and well-being, and that would help us to prevent stigma within the society, as well as within our own workspace, considering healthcare professionals are also one of the vulnerable groups subjected to mental health issues due to multiple reasons, which can be also discussed, but I believe I have limited time, so I will stop here.
Brilliant. Thank you so much, Salman. You're getting a lot of love from the audience, rightly so. Very interesting to hear you talking about a role of doctors in reducing stigma, not just about competences around delivery of mental health care. Perhaps we'll pick up on that later. Just to remind everybody, as we're hearing from our panelists, do put your questions in the chat because we'll have time to address those shortly. So next, we're going to turn to Sanka. And thank you, very complicated questions. So what is the role of family physicians in the delivery of integrated mental health care? I think that's the easier one. What's the importance of addressing leadership and advocacy as part of training initiatives? Over to you.
Thank you, Charlotte. Yeah, so as a family doctor's perspective, I would like to first answer the first question about integrating mental health care to primary care. So we know that as family doctors, when you take family physicians, the term family physicians, general practitioners, all I'm just telling family doctors. I'm just taking everyone as one term, that's family doctors. So we know family doctors are the people who are in the first contact of, in the community. They are based in community, so they are providing the first contact care. So when you take the first contact care and the community's prevalence of, let's say, psychiatric illnesses or mental health disorders, it's a very, a large number. For an example, when you take the primary health care, it has been found that about 25% or quarter of the reasons for encounter is related to some sort of a mental illness. And sometimes 10% of them are depressive disorders. And apart from that, if you go through many of the consultations, we know that they don't have well-explained physical reasons. So they are medically unexplained. More or less, every organic disease has a part to play with psychological health as well. So this gives a very good background for, or say, reasoning to mental health care to be integrated with the primary health care initially. The second thing is, when you take the mental health illnesses, most of them could be diagnosed, referred, and managed, and also followed up in the primary healthcare level. So this is another reason for us to justify justify the importance of integrating mental health care and primary health care. So this is very easy to tell, but the thing is, it's very challenging when it goes to the practice, because a traditional medical practice or traditional primary care doesn't include much of mental health care. So here we need some bold decision makers. So it's just not about the clinical knowledge. It's all about soft skills like leadership skills, advocacy, and also change management. So here, only I come to your second question. So to integrate mental health care into primary health care or primary care, we need to train family doctors, not only about psychiatry or clinical care related to mental health, but also the leadership skills, advocacy, team-based care, and how to function as a leader to do this transformation, the practice transformation to a place where integrated mental health care is offered to the clients. So Wonka identified this very well, and a few years back, we started a pilot program integrating mental health care and advocacy program. So what we did was a bunch of young doctors, motivated young doctors, were selected from low and middle income countries, and they were asked to identify a mental health problem or some problem related to their practice, and they were trained in leadership, advocacy, etc., and they were allowed to provide solution for that problem, which was actually happened at the times of COVID. But despite all the problems occurring at that moment, that was a great program, and they actually, I think, provided us evidence to tell that the training of leadership, advocacy, etc., is very important in this practice transformation. And now we are in the second phase of the program, of the pilot program, sort of a beta testing of the program, thinking of a future training program, better training program. And we can see that the previous trainees are now serving as faculty, and they're sharing experience, the previous experience, with the new trainees or scholars. So in a nutshell, it's we can very well identify the importance of integrating mental health care into primary care. And to do this practice transformation, just the clinical knowledge is not important. So it is a must to train our family doctors in leadership skills, advocacy, and change management.
Brilliant, fantastic. So thank you so much for highlighting those broader sets of skills and more sort of system-based thinking to help make this more of a reality, this pre-service training. Now let's go to Farjana. So Farjana, my question for you is, how does BRAC play a role in effective capacity building of the health workforce on mental health in Bangladesh?
Thank you. Thank you, United Mental Health Action Network, for inviting me again as a speaker. As you know, BRAC is established after the Liberation War of Bangladesh. So since 1972, after the Liberation War, BRAC has been working in the primary healthcare to create a scalable solution for attaining national target and global standard. Through our community health worker and the engagement with these human resources, those who known as Shastu Kurmi and Shastu Sevika, they play as a game changer in our community level. They empower the community by enhancing their understanding of health issues, fostering and create a demand to have a high quality of services and bringing the gap between the community and the healthcare system. And along with our community health worker, we also have the project officer, paramedic, nurses, medical officer, who have been working on maternal, newborn, child, adolescent healthcare, non-communicable diseases, nutrition, tuberculosis control, malaria, eye care, rehabilitation, and support the physical disability, and of course, the mental health care. So we do have separate training unit for our field staff, and they are getting the regular basis essential training for primary healthcare services. And we have started our mental health project with the collaboration with Bangladesh government to integrate mental health service into primary healthcare. So through our project period, we got the experience that the community health worker who have been working for quite long period of time have some sense of dealing with the mental health issue. But as they do not have the training or the background of the mental health issue and how to address them, they do not able to give the correct intervention or identification of mental health issue. So we have started to think along with our project that why not we give the training all the community health worker and the rest of the professional who have been closely working in the community level, like paramedics, like the project officer who have been working in the health system in the primary health care, the nurses and the medical doctor. So we have started to work in two small areas in urban and rural. So now we are thinking to scale up with other area where our insight and experience people with mental issue can be utilized in the other area. So when I provide the community health training to the community health worker, they have easily linked the mental health issue with their previous working experience. And people share their mental issue burden and stress with our community health worker and also the medical doctor and nurses. But as they do not have the training that I have already mentioned, they do not able to identify and recognize the issues of the people, but the need is always there. So we have started to work on this area that we will bring another mental health professional in our training unit, and this unit will work closely to our rest of staff to get the mental health training to the medical doctor and the nurses and the rest of our staff. So the commitment we have got from our community health worker or our staff, that they have the willingness to know about the mental issue. So as we know that they are working in the physical health closely with the community level, and there is always embedded issue with mental health. So if we give the training to the staff, like as I mentioned, they will able to recognize and identify the cases, and they will provide the proper information to where to get the services. And I do believe it is the high time that we have to think that the mental health is not a separate aspect in terms of health. It is a part of health. So if we give the training and we distribute the tasks with the other staff, not only mental health professional, also the who have been working in the physical health. If we give the training, and they will able to give the first aid service in the community level at least. And as we know, we have the budget constraint, we have the lack of resources in terms of mental health professional. And if I say some statistics in terms of our country, that according to WHO, neuropsychiatric disorder is around 12% in our country, and only 0.44% is only budget allocated in the mental health service. So in our budget constraint area and low resources in our country, we wouldn't be able to create separate mental health cadre for the community level. So we have to think how we utilize our existing resources that is already working in the community level and provide the training and distribute the tasks among the primary healthcare, so they're able to provide the community level at first care. So we do believe that it's a huge task, and we have to work on right now. And I believe that it cannot be done any NGO and government level alone. We have to work on together. So this year we have started to work on, and I would like to echo with the Shankar that it's not about the training or provide the information to the medical officer or nurses. We do have to take the responsibility in the leadership to advocate mental health issues. And mental health issues, something is not about that the person who need the mental health issues, who have them, not the service that only need for who have the mental issues. It's require everyone. Mental health is something like we need everyone to acknowledge the issue first, then work on it. So that is from my side. Thank you.
Brilliant. Thank you so much. And I think we've all heard stories of community health workers having lots of kind of add-on trainings again and again. So this idea that integrating it in a kind of much more sort of integrated with their overall pre-service training, the advantages that that could bring. And again, you highlighting those kind of additional competences that are required. We're now going to go to our recorded message, and I'll just first of all read the question that that David Stewart from the International Council of Nursing is responding to here. So he's been asked, what role does your organisation play in integrating mental health training into nursing education, given its pivotal role in advancing overall mental health care? So now we'll go to the recording.
You know, what an honour to present some of our work within ICN. 2 years ago, we released a report basically looking at the mental health nursing workforce. And part of that was to understand what is the current situation. And what we found was that there are around 300,000 mental health nurses around the world, which is by far the largest provider of mental health services around the world. But there was huge disparity between countries, within regions, and particularly between income levels. There were large disparities in the workforce. And so one of the things that we tried to investigate is we have a massive shortfall, but what's the pipeline into this profession? What's the pipeline into specializing in this area, and particularly in undergraduate education? One of the things that we found, obviously, was that there was a lot of stigma, not just towards patients, but also towards the professionals themselves. And a lot of this came because there was not this exposure that we would have hoped in undergraduate education. So when we had a look and we surveyed a number of countries, what we found was quite concerning to us. We found that at least 1/3 of countries had no clinical placement hours required within a kind of mental health setting. And sometimes many of those countries didn't even have a theoretical component either. And we had more than half of the countries who responded saying that they had less than 80 hours, which is a very insignificant amount of time to actually learn. And when we did find that people were doing placements, often it was in these high acute institutional based care. And so it gave a very distorted kind of understanding, particularly of the burden or the need growing. And so we were looking at, well, what are some of these things that can be improved, particularly around this area? And certain things came to light in that, and particularly when we looked at the education providers. Often people providing the theoretical content weren't equipped with the knowledge, skills, and attributes required to also teach in this particular area. And so it's a really important strategy for us to go, wow, how do you have a pipeline of nurses wanting to move into the profession if they're not exposed to it in this undergraduate program? But also because all nurses at some part of their journey will be, managing or working with people who require treatment or care in some way or another. And we wanted to move it beyond just this biomedical understanding to one that embraces particularly a nursing philosophy of being that advocate and working with that patient-centered care, empowering them to be involved in their shared decision. So as a result of that report, we've been working now towards another one, which we'll be releasing very shortly, about guidelines for mental health nursing. And it does cover the prerequisites for, all nurses, which we see all nurses having some kind of minimal levels of education. But then as they start to progress in that more specialization, what are the competencies needed to progress, to learn and develop even more? And so we've sort of got this career trajectory that we're doing with undergraduate education, their alignment. So some of the things that in particular we're trying to do is we're trying to encourage particularly regulators to incorporate their national health priorities into their competencies within nursing education. And we want to see particular things throughout that, whether it be, identification, care, treatment, ethics, law, all those different components. We want to make sure that there's a minimum standard of competence within there. We believe it begins with educators, with our regulators, and other core components. We try and provide advice, particularly to all different levels of providers, about how they can improve the education. So thank you for just that brief overview.
Brilliant. So again, we're hearing about sort of standardization here, quality, and more about attitudes and stigma reduction as well. And just to alert you, in the chat, Sarah's put a link to the Lancet Commission on Ending Stigma and Discrimination in Mental Health, which was published last year, and perhaps speaks to one of the questions we have in our chat, which is about how do we start to address changing competences and attitudes. Maybe we can start with that question. So that commission certainly has some answers to that. How do we reduce stigma in health workers, including in mental health workers, but also in general health workers? So is there anybody on the panel who would just like to talk about, is there anything that is known about pre-service training that seeks to change those kind of attitudinal components?
I could reflect on that, Charlotte, it's okay. When I think there's a number of approaches we've learned about in developing this guidance I mentioned earlier. One of the ones that I think is really nice and that we try to highlight in the document is approaches that involve contact with people with lived experience of having a mental health condition, and showing medical students in the educational setting that there is a pathway to recovery for most people, and showing that the nuances and the differences to what recovery means to individuals. There's a nice program called READ, Responding to Experience and Anticipated Discrimination, that's been implemented in this way, that involves people with lived experience as co-facilitators of an anti-stigma type of training. And I think one of the nicest component is just that showing that contact and interaction with persons with lived experience who can sort of reduce stigma by that interaction, kind of dispelling some of the myths that students and others might have towards people with mental health conditions. And this is an evidence-based approach that actually has been shown to shift attitudes and result in more positive, less discriminating attitudes towards people with mental health conditions. So I think it's one example. There's others, but it's a really nice one to highlight here.
Thanks, Brandon. And I think just look at one of my colleagues from Ethiopia, Tadessa Kasai in the chat, is actually asking about how people with lived experience can be engaged in the training of medical students and other nurses and doctors and non-specialists. So I think you've just spoken to that. But if you have, Tadessa, if you have further comments, please put it in the chat. Anybody else from the panel want to weigh in on the issues of changing attitudes? I was wondering about Salman, because you mentioned stigma so many times. Have you got some experiences about how that can be achieved?
Yes. So I would like to also talk a bit about the experience, personal as well as the work the organization I'm a part of has done to ensure that we are actively addressing stigma, because due to multiple issues or multiple factors which are limiting us from approaching mental health from a holistic perspective. We, as in our organization, took matters in our own hands, and we sort of worked on a peer-to-peer educational workshop, which is called Mental Health Essentials for Future Healthcare Providers. We've been working on this workshop since 2019 in various physical venues around the world, in our pre-general assemblies, pre-regional meetings, as well as sub-regional trainings. So the workshop is a 3-day workshop that's divided into multiple modules based on adult learning theory. Just to name the methodologies used, we had storytelling, presentations, hands-on techniques, small working groups, as well as reflections. So essentially what we try to address in the workshop is the overall mental health burden. Apart from that, the social determinants, as well as various factors influencing mental health care, as well as stigma and how that is related to discrimination, and how that's related to social media for good and for worse as well, highlighting how social media is a boon and a bane in mental health, as well as training on leadership and activity management and communication skills to ensure that we not just know how to talk to our future patients, I would say, but also have the capacity to, let's say, further the knowledge, or further share the knowledge that they have learned, and further share the skills that they have learned to their peers. So that's essentially what we have done on a capacity building and development perspective. We've also been supporting our members on grassroots levels through their activities to ensure that they're reaching out to different stakeholders, patients included, their own peers included, to talk about stigma and to talk about mental health from a holistic perspective. And we have a system called IFMSA programs, and one such programs out of the 13 is mental health, that specifically works on it all year round.
Fantastic. So I've heard you mention a few key points there, something about making sure people are accurately informed, so that they really understand about mental health and its sort of social context, not just about biomedical components of mental health. But you've also talked about people, perhaps attitudes improve when people feel equipped, so they're not overwhelmed and they know what to do in response to something that they recognize as a need. So I think those are really critical points as well. Do keep the questions coming in the chat. We've got a couple of questions we prepared earlier. So maybe we start with the second one, actually. So I'm going to ask perhaps panel members who've not spoken to kick off by responding to this question, which is, how can we inspire others to take proactive steps within their spheres of influence to advocate for, to support, and to implement improved mental health education within different training programs. So, I mean, I feel like we are the coalition of the willing here on this call. You know, we're the people who are motivated and interested to do this work. But clearly, this is not something that is always an easy sell to non-specialists. So, how can we do that? How can we inspire things to get going? Fajana, do you want to have a go at this?
We have facing this problem actually when we started to work with the integrating mental health primary healthcare. The first experience was not good because that feedback we got from the community mental health worker that we already have a lot of in our plate and we are supposed to work on more. So it takes a lot of time, and what we do, we provide the training regular basis. Like they got training after quarterly, like after 3 months they got a training, refresher training on mental health. And as they are working on so many issues, we provide the burnout management each month. Like they got the burnout management from our team. And we also do recognize the hardship they are doing, and we trying to provide little bit like incentive for them for doing these extra tasks. So this thing, I think this kind of thing is making the easy to motivate in work, but still it's a lot way to go, I think. And I think a government should recognize that mental health issues need to be recognized and should be included in the primary health care, and take the proper step or any policy level changes for recognizes these extra tasks they need to do. So I think this can be done, but I think it should be forced or motivated from the government side or the NGO level to continue this initiative. It's not usually the NGO level, we do some short-time project and we do this kind of intervention like 2 and 3 years. Then the project is ended, the intervention is like we put in the basket. But this kind of initiative should be taking a long time, and the impact will when the medical officer or the nurses able to see that this little bit effort make people life better, and the rapport with the patient or the beneficiary getting much better, so they will easily encourage to do this kind of tasks. I think this is the thing we can do.
Thank you. So we can help to inspire people by getting people in leadership who've got that longer term vision and able to kind of reach out to broader numbers of health workers over a longer period of time. That's very helpful. And actually, I'm thinking of something Salman also said about sort of peers, inspirational kind of peers who've kind of understood how mental health fits in and can be very compelling for their colleagues, perhaps to inspire them as well. Sankar, I don't want to put you on the spot, but do you have anything that you would like to add?
Yeah, of course, yeah. Because when I was talking about the advocacy could be in different levels. Like, I would like to see our family doctors to talk about the importance of mental health care and integrating it into the private care in every level, like probably the colleagues level, the community level, and they can of course influence the organizations and politicians as well. I think because the policy, I mean, most important thing, one of the most important things would be influencing the policymakers. So when we talk about advocating the change could be in each and every level of care and each and every level of policy making, and I mean taking decisions. And also about your question, Charlotte, about how can we inspire the others? I think as family doctors, we always think about the team. The care should be team-based care provided to our patients. So we have to not only empower our family doctors, but also we have to empower our team. So I believe in, and we believe in empowering everyone and sort of leading. I mean, leadership could be taken by each and everyone in different instances. So when we were doing this advocacy and leadership program, we also talked about team-based care and how we can change this, different levels of leadership. For an example, it's not only the doctor leads. Sometimes it could be the nursing officer, it could be the community health worker, or even the receptionist could lead in certain instances. They could lead this team because they have different sort of competencies, and they work in different levels. And sometimes they can even advise and even recognize certain problems before it is recognized by the doctor. So I think this advocacy in every level, and also empowering the entire team, not only the team leaders, is very important in inspiring others and implementing this improved integrated care in our community.
So very much taking a system-based approach, sort of making sure everybody is equipped and on the same page is a way to inspire change. Thank you. So we've got some more questions in the chat from the previous session, actually. I don't know whether anybody wants to have a go at any of these. So the first one is, can lived experience be a boon or a burden for medical professionals? So I presume that means in a medical professional having a lived experience of a mental health problem. So interestingly, it has already been brought up in the discussions that the benefits of delivering mental health care is also that health workers have their own mental health needs that need to be responded to, and potentially this integration could benefit. And somebody mentioned burnout as well. Does anybody want to reflect on that at all?
May I?
Of course.
So when we recruited community health worker in our project in mental health, we have recruited someone from the community who have the lead with experience in mental health issues. So we have got that population have huge motivation, have better technical grip in skills in terms of counseling, rapport building, because they have been suffering from their own life for that issues. So I do believe if we recognize the fact that the people with lived with experience can contribute better way in compared to those who do not have those experience, but that thing need to be bring in a plate in our conversation, because in our culture context we still struggle with this concept that a person with lived experience cannot be performed well because he has some mental issue. He can't solve his own problem. How can he solve other? So this kind of stigma need to be break at first. Then we can include the people with lived experience in our discussion, in our strategy planning, in our action plan, and of course in our working process. So this, I think stigma need to be break at first about this kind of taboo we have still holding in our heart, that people with lived experience cannot do better than others. So later, step by step, we must include them, because without them, we can't do actually better implement in regarding mental health. Thank you.
Thank you. It's reminding me of my colleague, Dr. Medhin Salamu from Ethiopia, who did some work on burnout in health workers and found that there were much more stigma about their own mental health and their expectations that they had to kind of uphold this front of being fine and never being vulnerable to mental illness, and how stigmatizing it was for them to access their own care, to look after their own mental health. So it is all tied up with this topic, and I think is a potentially critical part of that pre-service training as well. So I think let's move to the next bit, and then if anybody has any last comments at the end, we can also accommodate those. So we're going to go round each panel member and ask them to complete the tweet. I don't know whether it's even called a tweet in these days, but anyway. So This is the start. So to effectively integrate mental health training in pre-service education, we must ... Brandon, you're first up.
So I like this question. It's always nice and catchy in these webinars. I'm horrible at answering it, but I'll try. I think we must take a long-term view, understanding that impact will not be immediate, but it can be immense. Because we're talking about something that is long-term, right? This won't be seen tomorrow, but we'll see it someday.
May not be immediate, but maybe immense. Brilliant. Okay, who's next up? Salman.
All right, so perhaps from my side, to effectively integrate mental health training in the education of doctors and nurses, we must meaningfully engage with young health professionals and students in the first one being advocating for addressing stigma on all levels, and the second point being developing relevant competencies in curricula to ensure evidence-based and human rights approach in treatment.
You used up all of your tweet characters there. Brilliant. But it's so true. You know, often younger generations are more open-minded or can have different ways and can change things that are sort of rather solidified within health professions. So those are great points. Sanka.
Yeah, I try to be in line with what I told. So yeah, to effectively integrate mental health care training in the education of doctors and nurses, we must focus on leadership and advocacy skills.
I don't think many people are going to argue with you there. That's great. Hajana.
It's very difficult to say a lot of small word in these great topics. I would like to say we must include mental health into primary health care or physical health, and everyone's matters.
That's wonderful. That's wonderful. Well, we've actually got a few minutes left. One of the things that has really struck me as we've been talking is thinking that how we've been conceptualizing the role of the health worker as being much more than somebody who just sits there delivering a particular sort of clinical service. We're talking about them being advocates, inspiring others, leaders, addressing stigma. And I'm wondering, you know, with this focus of this webinar is really thinking about low and middle income countries, but I'm very much thinking about, you know, what we can say to high income countries. Maybe I can ask Brandon, is this pre-service training, is this also going to be for high income countries as well?
Yeah, thanks, Charlotte. That's a great question. I think absolutely it is. I think we all have the experience, regardless of what country we've come from, where we've been in a healthcare setting and interacted with a healthcare provider who some might say doesn't have a good bedside manner, but in any case, we weren't supported in that interaction. On the other side, I think many of us have also been in the interaction with the healthcare provider where maybe ourselves or a loved one are in a very serious situation, and one interaction with a friendly nurse or a kind doctor made so much the difference in our experience in that healthcare setting. And that ranges all the way then to thinking about also interacting with the health system when having a mental health condition, neurological condition, substance use condition, you know. So I think our guidance is going to be focused on all range of countries, because I think this is a challenge in every country. We've seen examples of gaps in this education from many high-income countries as well. So I think we're certainly not saying this is an issue only for low and middle countries to focus on. I think it's for everyone.
That's brilliant to hear. And Brandon, do we know when the guidance is going to be published and how people will be able to find out about it?
So I can't commit to an exact date, but this year is our target, and hopefully in the first half of this year. But let's see. That's our target. We're moving a bit slowly because we have very little budget for this project. It's so important to us, so we're still moving forward with it. So this year is the target, and we'll hopefully be able to share more information about it, I think, towards the summer of this year.
Brilliant. Thank you so much. So there's just something in the chat, Adam Sheffer. Training of individual workers will not solve defects in organizational structures. So again, highlighting the systems issues and how we need to have a very joined up way of approaching this issue. You're right. without solving those factors, workers will continue to be overburdened and burned out. So you will be able to continue the discussions on Circle. I believe it's called Circle. There's no more webinars. I think, Divya, you said in the chat in February, but there will be further webinars that you can sign up, organised by United for Global Mental Health. I'd like to give a really warm appreciation to all of our panellists who've obviously brought their rich experience on this topic, and I hope I can see visually that everybody has been enjoying the wisdom that you've shared with us. I'm gonna be monumental and finish early because that's good for all of our mental health. It's just a bit of a bonus. You've got a 5-minute break now before your next meeting, but a huge thank you to everybody, and thanks for joining as well. Thanks a lot.
Thank you.
Thank you very much.
Thanks, everyone.
Thank you. Bye.